Endometrial cancer is fortunately one of the cancers that presents with a symptom of bleeding, which is why it very often is detected earlier as opposed to other gynecologic cancers. And so a woman who has postmenopausal bleeding, which is bleeding is defined by occurring after 12 months of no period, is evaluated for that and taken very seriously. Also, women with abnormal bleeding should be evaluated and taken seriously too. But postmenopausal bleeding is defined by no period for a year and then an occurrence of bleeding. Up until recently, it was considered acceptable to start with a pelvic ultrasound. And it's thought that if the lining of the uterus was under 4 millimeters, that's the endometrial stripe is under 4 millimeters, the incidence of endometrial cancer is very low, and could be monitored and further tested if another occurrence of bleeding happened. So this new guideline is different, and it's suggesting that both a biopsy and an ultrasound be done even with the first occurrence of bleeding. I think this approach is really going to be beneficial for women, and I think there are a lot of reasons why. We can start with just an ultrasound, right? An ultrasound is not always, um, first of all, there are different quality of ultrasounds that are obtained for women having a pelvic transvaginal ultrasound to look at the endometrial stripe. And sometimes if there are other things going on in the uterus, such as fibroids, the entire lining is not visualized. And so the report might say what is visualized appears normal, but there certainly could be something else going on inside the lining of the uterus that's not detected by this ultrasound, but you read that it looks okay, and so we leave it alone. That's one thing. Second, there are certain endometrial cancers, specifically these high-grade, very aggressive type endometrial cancers that happen to be more common in Black women that are not detected by the ultrasound. And so you don't see a thickened lining in these women, but those are actually some of the more aggressive types of endometrial cancers. And third, I think, as we're all aware, access to healthcare is really challenging if we don't do that initial biopsy at the time we're seeing our patients, there can be a delay of care. So, for many reasons, to address this as soon as we see an episode of bleeding will make perfect sense for the patient to do both the ultrasound and the biopsy at the same time. The one drawback of this is that an office endometrial biopsy can be uncomfortable for women. It's a painful procedure, and some might opt not to want to do that initially. We currently offer and encourage the use of some topical or local pain medication for an endometrial biopsy, which can really make it less painful. And also, sometimes you can use medication that can help dilate the cervix and use that ahead of time to make the procedure easier. Also, misoprostol can be used the night before an endometrial biopsy to make the procedure easier for patients. So if you know that they're coming in with postmenopausal bleeding, you can prepare for that. If you know a patient is coming in with postmenopausal bleeding, which sometimes we don't know what they're coming in with, we can prepare ahead of time and maybe even counsel the patient about the procedure ahead of time. And that would allow for, again, giving misoprostol the night before if it's indicated, especially if they've never had a vaginal birth or never had any kind of cervical procedure. Having supplies available, such as lidocaine gel or 1% lidocaine that can be instilled into the cervix, is also helpful so that you can do that at the time of the procedure. What I said earlier about the reasons why it's indicated to do this is a good way to counsel the patients that the ultrasounds aren't perfect, that some cancers aren't detected with an ultrasound, and that the sooner we diagnose something, the sooner we treat it, are all important facts to share with our patients to encourage them. I will say, that being said, um, not all postmenopausal bleeding is very common, and not all postmenopausal bleeding is cancer. So I think also the care of postmenopausal bleeding needs to be um, individualized. the nature of the bleeding. If it was just like a little bit of spotting after sexual intercourse, that could certainly be from vaginal atrophy, and that needs to be understood that that might not be the reason. That might not be endometrial cancer. So there are you have to take the patient's history and understand individually what's going on in using these guidelines because they are just guidelines. So they're not for everybody. And if you know your patient and know you'll be able to get them back in for follow-up after an ultrasound, then maybe that's appropriate for your individualized patient.